Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. Today we are going to discuss one topic from operative surgery in ENT, and this is one of the operations which even undergraduate students should know every bit of. When I say every bit of, it means that even the surgical steps, because in operative surgery for undergraduates, most of the topics are just that you must know the definition, indications, contraindications, and complications of surgeries, but operative steps are not required in detail. But there are only few operations for which you have to know each and every detail, that is the surgical steps of the operation as well, in addition to of course the indications, contraindications, and complications of that particular surgery. So today's topic is one of those which is that you must know every bit of. So let's start today's discussion, and this is regarding the nasal septal surgery. And before starting, you are requested to subscribe, like, and share the channel so that you are not going to miss important topics in detail. So for nasal septal surgery, the most common operation which was being done, when I say which was being done, it means it has been replaced now some modern techniques. So this was what we call as SMR. So SMR is abbreviation for submucous resection of the nasal septum. This is a terminology which is familiar with all and is being used by everyone, but technically it is not submucous resection, because mucus, you know, that is the secretions, and when you will put a nasal suction tip there inside the nasal cavity, all mucus will be sucked out. So then there is no mucus, then how you can go sub in the submucous plane? So this is actually, it is what we call as submucoperitoneal submucoperiosteal resection, but still it is prevalent, so we will use it as submucous resection. So the definition of SMR is a radical surgical procedure in which whole of the nasal septal cartilage except a strut along the dorsum and caudal border of the nasal septal cartilage along with bony spur is removed. So in this definition there are few words which are very important. One is radical surgical procedure. You know, 3-4 decades before, mostly the surgical operations, they were radical surgical procedures, but in last few decades now the surgery has been shifted towards what we call as conservative surgical procedure, because over the years we came to know that the advantage or the treatment can be there even with conservative surgical procedures. So then why to go for radical surgical procedures? Because radical surgical procedures everywhere they will cause more trauma to the body, more deformities post-operatively, and more complications as well. So when the purpose can be achieved with conservative surgical procedures, so then we should shift. For example, this cholecystectomy, it used to be open cholecystectomy. Still in some cases you have to open the abdomen. Nowadays we can do laparoscopic cholecystectomy, we can do even laparoscopic appendicectomy. So similarly SMR was a radical surgical procedure, and even there was very minor deformity or deflection of the nasal septum. Still these radical surgical procedures used to be a standard operations that you have to do from step 1 to last step, irrespective of that what is the indication for that surgical procedure. It used to be a standard procedure. So SMR is a standard procedure in which whole of the nasal septal cartilage, that is the quadrilateral cartilage, was removed, but except a strut along the dorsum of the nose and along the caudal border. It was left behind to support the external framework of the nose and the columella. So, and along with, of course, bony spur was also removed. So this was done in adults, because when you have to remove almost whole of the septal cartilage except a small struts along the nasal dorsum and caudal border. So all cartilaginous framework has been removed, so it cannot be done in children, because during growth period nose has to grow, face was growing in that teenage. So if sport is not there, then the nose, there can be saddle nose deformity or retraction of the columella, etc. So it was done in adults, and usually it was done under local anesthesia. Nowadays general anesthesia is much more safer as compared to it used to be few decades before. So nowadays we do surgery under general anesthesia. So it consists of elevating the mucoperichondrial and mucoperiosteal flaps. So that's what I mentioned in the beginning, that this is submucoperichondrial and submucoperiosteal plane where we have to work. So submucoperichondrial and submucoperiosteal flaps used to be raised on either side of the nasal septal cartilage, and then septal cartilage was removed along with the bony spur. The indications, a very common indication for SMR is used to be deflected nasal septum or DNS, which is causing the nasal obstruction and recurrent headaches. Uh, when we were discussing the deflected nasal septum, and the link for that video is there in the description, you can check it out there, that we defined deflected nasal septum as a deflected nasal septum which is causing symptoms. Because if deflected, there is geometrically or on examination we see a deviated nasal septum, we will not label it as a DNS until and unless it is causing symptoms. And out of the symptomatology or the clinical features, nasal obstruction is the most common clinical symptom for deviated nasal septum. Then deviated nasal septum, which is causing obstruction to the ventilation of the paranasal sinuses and middle ear due to eustachial tube dysfunction, and resulting in the recurrent infections of the sinuses and the middle ear. Then in indications, if there is recurrent nasal bleeding from the nose due to a septal spur, because if there is a sharp spur, bony spur like that, so mucoperiosteum is stretched over that, so it has become thin. So even trivial trauma, just as we just mildly blow the nose, or due to the air current, it becomes dry and crusting formation, and when it is being removed those crusts, there may be nasal bleeding. So if there is recurrent nasal bleeding and the cause of this epistaxis is that bony spur, then we have to go for the nasal surgery procedures. Then if we need to do the external rhinoseptoplasty, that the patient is having external deformity of the nose along with deflected nasal septum, so as a part of rhinoseptoplasty we have to do this. If we need this septal cartilage as a graft for example in septal perforation repair or in external rhinoplasty, we need this cartilage graft for the support of external osteocartilaginous framework of the external nose, or in tympanoplasty where we have to repair the tympanic membrane with cartilaginous graft. So we have to harvest this septal cartilage, and then we have to do this. Then if we have to approach the sphenoid sinus, for example, or the Vidian nerve for through this vasomotor rhinitis, we have to do, for example, Vidian neurectomy, or we have to approach the pituitary gland through this transseptal approach. Then as an approach we have to do the septal surgery. So these used to be indications for SMR. And the contraindications for this nasal septal surgery is acute upper respiratory tract infection, because whenever there is acute infection, there are chances of peroperative bleeding and postoperative bleeding more as compared to those who are infection free. Then because it was a radical surgical procedure in which almost whole of the septal cartilage has to be removed except a small strut along the nasal dorsum and the caudal border, so it could not be done below 17 years of age. So patient should be adult for subjecting for the SMR. If a patient is having bleeding disorder, that would have been a contraindication, or the patient is having some systemic disorders like uncontrolled hypertension and diabetes mellitus. So these are the surgical steps diagrammatically. I will try to explain all these. That first, under local anesthesia, it used to be done. Nowadays, as I said, we will do with endotracheal intubation under general anesthesia and the throat back around the eustachian, this endotracheal tube. And patient is lying supine with head elevated on the operation table, 45-degree angle above. Then we will infiltrate with local anesthesia in the submucoperichondrial and submucoperiosteal plane, so that this xylocaine will 2% xylocaine, which is containing adrenaline will cause vasoconstriction, so less bleeding operatively. And then we will incise this sub mucoperichondrium only, and this should be 2 to 3 millimeter behind the anterior end of septal cartilage. So if this is the anterior end of septal cartilage, 2 to 3 millimeter behind, here you can see this is the incision. We will incise only the mucoperichondrium on this side, and this incision is called Killian's incision. Then we will raise this mucoperichondrial flap on this side. Once the flap has been raised on this side, then we will give an incision over the cartilage from the same side, and then we will go on the other side of cartilage, and from there also we will raise the mucoperichondrial flap. So now in this picture you can see that the prongs of the nasal speculum are, one is on one side of septal cartilage and the other one is on the other side of septal cartilage, and cartilage is there in between now. Then we can remove this septal cartilage, whole of the septal cartilage, except a strut here along the columella, caudal border, and one strut along the nasal dorsum by Bollinger's swivel knife or by the Lux forceps. Then once the cartilage is being removed, both mucoperichondrial flaps, they are approximated, and the stitch is applied at the incision line. And if there is a bony spur, we will raise that mucoperiosteal flap also. After removing this septal cartilage, we will remove that bony spur with hammer and gouge. So this is how we will complete the SMR operation. This is the description. I just mentioned that after infiltration of subperichondrial infiltration with 2% xylocaine with adrenaline, Killian's incision, which is a curvilinear incision 2 to 3 millimeter behind the anterior end of septal cartilage, elevation of the flaps, incision of the cartilage, and then we go on other side, elevation of opposite mucoperichondrial flap and mucoperiosteal flaps, and then removal of the cartilage and the bone cartilage by Bollinger's swivel knife or by the Lux forceps, and bony spur is removed by gouge and hammer. And then we have to preserve a strip 1 centimeter wide cartilage along the dorsal and caudal borders of the nasal septum, and then anterior nasal packing is done, which is removed after 24 hours. So this is another diagrammatic representation that here we will, this is the incision in the mucoperichondrium, and then with Freyr's elevator we will elevate the mucoperichondrial flap on this side. Then we will incise the cartilage, and with the mucoperichondrial flap we will go on the other side, and from other side mucoperichondrial flap is raised, and then we will remove the septal cartilage, leaving a strut here along the dorsum and the caudal border. And if bony spur is there, we will raise the mucoperiosteum over that, and we will remove this spur with hammer and gouge from here its root, so that the septum is being straightened. So this is Killian's incision. You see, this is the caudal border. So 2 to 3 millimeter behind and parallel to the caudal border, we give the incision in the mucoperichondrium. This is what it is called as Killian's incision. If we give an incision just over the caudal border, then it is called as hemitransfixation incision. This is also called as Freyr's incision, which is used in septoplasty. I will come to that later on. And repeatedly I was reiterating that the strut should be left along the dorsum and caudal border. So this is the diagrammatic representation that this piece was also here. So we left this strut along the dorsum. It should be 1 centimeter wide, and 1 centimeter wide this caudal border strut is left, and rest of whole of the septal cartilage is being removed. So this piece is being removed, which can be used as a graft material as well. And if there is a bony spur along the bones of nasal septum, those can be removed with the hammer and gouge. So what can be the complications? If anyone asks you about the complications of any surgical procedure, always think about first about the complications of anesthesia. Whether think about that this particular operation is being done under local anesthesia, then what can be the complication? If it is under spinal anesthesia, what can be the complications of anesthesia? If it is being done under nerve block or surface anesthesia, what can happen to the patient? Any adverse effects of those anesthesias? Or if the patient is being undertaken general anesthesia, what are the complications of general anesthesia? So someone ask you in viva or even in theory, complications of surgery, always start and give a heading, complications of anesthesia. After that will be the complications of surgery itself. So as you just saw that this is a surgical procedure which is a radical surgical procedure, so complication rate was very high. So there can be bleeding can be there in any surgical procedure, because whenever we are using the knife, of course there will be the bleeding, and this bleeding can be of three types. Some other day we will talk in detail. This surgical post-op surgical bleeding is of three types. One is primary hemorrhage, which occurs on the table. The other one is reactionary hemorrhage, any hemorrhage which occurs within first 24 hours. The word is within first 24 hours. It is not after 24 hours. So within first 24 hours, any bleeding occurs after any operation, that is reactionary hemorrhage, and any hemorrhage which occurs after 5 to 7 days after surgery, that is what we call as secondary hemorrhage. So post-surgical hemorrhages can be primary, reactionary, and secondary. Then there can be septal hematoma, because the undersurface of the mucopericardial flaps, they have got blood vessels, and when we stitch it at the end of, there can be collection of the blood there, that may lead to septal hematoma. Then damage to the surrounding structures can be there, septal abscess, septal perforation, because now only mucosal flaps are there, there is no cartilage in between, so there can be septal perforation. If we don't leave a proper strut along the nasal dorsum, then there can be saddle nose deformity, that is depressed nasal bridge later on. In addition to that, there can be retraction of columella, again if the strut along the caudal border is not appropriate of size, then there can be retraction of columella. If nasal hygiene is not being maintained and proper suction and clearance is not being done post-operatively, there can be nasal adhesions or nasal synecdoche formation. Flapping septum may be there, and then infections due to sinus and middle ear, or even CSF rhinorrhea can be there, very rarely. Now we come to that what it is called as septoplasty. And what is septoplasty? Now this is a conservative approach. First thing is that this is not a radical surgical procedure like SMR. So this is a conservative approach. When we say conservative approach, so much of the septal framework is retained. And how is it is retained? That either we only remove the deflected part of the nasal septum, or we realign the deflected part. So it means that this is a conservative surgical procedure in which we address only the deflected part of the nasal septum, and either the deflected part of the nasal septum is removed or it is realigned. I give you an example to understand this one. For example, a patient has got only a bony spur. Septum is there in the midline and there is a sharp bony spur. Previously, this patient used to be subjected for SMR, and SMR we just described, that is a standard radical surgical procedure. But with time we came to know that instead of, why to remove the septal cartilage in this particular scenario which I just mentioned, where the problem is only the bony spur, so we will remove only this bony spur and we will not disturb rest of the osteocartilaginous framework of the nasal septum. Secondly, for example, there is a septum which has got a only a deflection here in the anterior part, posterior part is there in the midline. So we will raise the flap here on this side, and then we can remove only this deflected part of the cartilage. So when this deflected part of the cartilage will be removed, rest of the cartilage is retained and it is realigned or straightened, so that most of the septal framework is being retained. No need to remove whole of to do the radical surgical procedure as it was used to be done in SMR. Another example, we know that deflected nasal septum, the main etiological factor is trauma. So for example, due to the trauma, this septal cartilage is being deviated towards, for example, one side, and it is being pulled due to fibrosis and scarring of the fracture line and the mucoperichondrium. So if we raise the mucoperichondrium there and we give partial crisscross incisions, vertical and horizontal, and then we just infracture it, so this septal cartilage will be straightened because that pulling effect has been released. So nothing to remove, but the deflected part has been realigned. So what I mean to say that there can be different scenarios from person to person or patient to patient, and in individual patients we have to tailor septoplasty procedure. So it means it is not any set surgical procedure, but to make it understand, anything less than SMR, which we do in SMR, anything less than that, if we do, that is a septoplasty. So this is a conservative surgical procedure in which only the deflected part either is removed or realigned, and I try to explain it with different examples of deflections in the septal, nasal septum. Indications, again the almost the same, that is deflected nasal septum which is causing the symptoms, then deflected nasal septum which is causing obstruction to the ventilation of paranasal sinuses and the middle ear. Then if there is a recurrent nasal bleeding from the nasal spur as a part of septorhinoplasty, we have to do as an approach to surgeries of sphenoid sinus, median nerve and the pituitary gland. And last but not the least is caudal dislocation. If you remember that in caudal dislocation, in case of SMR, we incise the mucoperichondrium 2 to 3 millimeter posterior to the caudal border. So if caudal border is being displaced or dislocated from the columella, it cannot be addressed with classical SMR procedure. While in septoplasty, we can address this caudal dislocation. So that's why caudal dislocation could not be addressed by classical SMR procedure. Contraindications are again almost the same, that is acute upper respiratory tract infections, then bleeding disorder or uncontrolled hypertension and diabetes mellitus. But in SMR, one of the contraindication was that the patient at least should be 17 years or above. Below, it could not be done, but that is not a contraindication in case of septoplasty. So it means septoplasty can be done in children as well, or any patient less than 17 years of age. So septoplasty can be done in any age group, you can say, while SMR can only be done after the age of 17 years. So again, the anesthesia, nowadays we do it under general anesthesia. Position is the same as we do in SMR, that is, or in any nasal surgeries, that the patient is lying supine with its head side is upwards, and then we infiltrate it with local anesthesia in submucoperichondial plane, and then we give the incision at the caudal border of the nasal septum. That is what we call as Freyr's incision. This is also called as unilateral hemitransfixation incision. So unilateral hemitransfixation incision or Freyr's incision is one and the same thing. So don't get confused. Actually, in case of this septoplasty, we can give the incision according to the deflection. For example, as I just gave you the example of a septal spur, for example, the nasal septum is exactly in the midline, but there is a bony spur. So we can give directly an incision over the nasal spur, and we can, elevate the mucoperiosteal flap over the spur, and we can remove that spur, and then we can repair it. Rest of the mucopericordial flap, no need to raise that even, isn't it? So there can be, and even for example, we can use the Killian's incision also, because if there is nasal septum and deformity is more posteriorly, so we can use a Killian incision. We can remove that deflected part posteriorly, or we can realign that deflection, and then we can do it. But most commonly, the incision which is being used, or usually the incision which is being used for septoplasty, or in a multiple choice questions they do ask is, then you have to mention Freyr's incision, which is at the caudal border of the nasal septum. This is also called as unilateral hemitransfixation incision. And then we raise the mucoperichondrial and mucoperiosteal flap, usually on the one side. On the other side, we have to, just elevate on the deflected part. So mostly only on the one side, the flap is being raised. And then we separate the cartilage from the vomer and ethmoid plate, and inferior strip of the cartilage is removed. And crisscross incisions, I just mentioned before that if this you feel that there is a very limited area of the nasal septal cartilage is deflected, and that is due to the pulling effect of, to release that pulling effect of fibrosis, just release that tension by crisscross incisions and you can straighten it. So there can be different options. So, to sum up, septoplasty is a conservative procedure. Much of the septal framework is retained. Only the most deviated part is either is removed or realigned. Rest of the septal framework is corrected and repositioned by plastic means. And mucopericordial, mucoperiosteal flaps are raised on the one side, and so that the blood supply is not compromised on other side. And this septoplasty almost have replaced SMR now. So this is that you make an incision on the caudal border of the nasal septum. Only the deflected part is removed. Rest of the septal cartilage you have nothing to do, and whole frame. But if in SMR, even the same deflection, but still you have to go for classical standard radical surgical procedure. So hopefully you would have understand the differences now. So complications, again, complications of anesthesia. If we are doing it under general anesthesia, you have to mention the complications of general anesthesia. And then surgical procedures, again almost same complications. Theoretically there is possibility of, which we just discussed under the heading of SMR, but of course you can now understand by the surgical procedures that the rate of complications will be far less in case of septoplasty as compared to a radical surgical procedure, which is SMR. For example, the septal perforation, less chances, because in SMR there is no cartilage in between two mucosal flaps, while here most of the septal cartilage will be retained. So less chances of septal perforation. This flapping septum, very less chances of in a septoplasty, because again there is cartilage in between. Similarly, retraction of columella, the chances are less. Depression of the bridge is less, because in SMR you have to leave a strut 1 centimeter. That may vary from surgeon to surgeon, that his assessment may be different. For example, he would have left only 5 mm, for example, and there may be ischemic necrosis later on. So saddle nose deformity, more chances in case of SMR as compared to septoplasty. So just to sum up, and sometimes they do ask in theory as well, the differences between SMR and septoplasty. So if you remember this slide, you can very well differentiate between these two. One is radical surgery, the other one I just mentioned is conservative surgery. So this radical surgery could not be done in children below 17 years of age, while this septoplasty can be done. In case of SMR, Killian's incision. In case of septoplasty, usually Freyr's incision, but as I just explained, that even other incisions can be used. But for undergraduates, you have to remember that Freyr's incision, which is also called as hemitransfixation incision, that is used for septoplasty. So flaps elevated on both sides, of course, in case of SMR, here usually are mostly elevated only on one side. Most of the cartilage is removed in SMR, while here most of the cartilage is preserved in case of septoplasty. Caudal dislocation could not be corrected by SMR, because in SMR the Killian's incision is given 2 to 3 millimeter posterior to the caudal border. So if the deflection is anterior to that incision, that could not be addressed with, while this caudal dislocation can be corrected with septoplasty. Perforation, or even the complication rate, is higher with SMR while it is less with septoplasty. So perforation chance is higher in SMR, here it is less. Same is post-operative deformity is less or almost absent. In case of post-operative saddling deformity, more chances in SMR. Revision surgery is difficult in SMR, while revision surgery is easier in case of septoplasty. So with that, we come to the end of today's discussion. So thank you very much for watching, and don't forget to subscribe the channel.